fog syndrome, which they call it as. Some kind of a, they don't have the kind of a dynamism that we used to have even after everything has recovered. Dyspnea, patient complain of dyspnea even if the CT scan appears relatively normal, scan starts becoming normal. Joint pains, chest pains patient can present with. Cough, it persists. They may not be as high as it was in the acute phase, but it persists in the post-COVID phase too. Anosmias, which we used to think is an early sign of COVID, they continue to have it. After discharge, they come back to you saying that they're having anosmia. Sika syndrome, dryness. Dryness is one of the features, dry throat, dry lungs, where they get a dry cough. They continue to have it. Rhinitis, red eyes, dyskinesia, headaches, one of the commonest symptoms with which the patient comes back to is sputum production. Lung changes occur, the ectasis that can occur, the fibrosis that can occur in these patients can cause bronchiectasis and sputum production can occur. Lack of appetite, sore throat, vertigo, myalgia, and diarrhea. If you look into the graph, more or less, most of the symptoms which are there in the acute phase, they can have in the post-COVID phase two, meaning that there is some kind of an immunological system that is at play in these patients of COVID disease, even after the disease has been is gone and has been declared as cured. Well, what's the usual scenario? The usual scenario is majority of the patients recover extremely well. They are the lucky asymptomatic carriers who do not come to hospital or probably they are checked because one of their kith and kin is a positive and they don't come to hospital. They do well. They don't need any medications. That's what the usual story is. Some develop oxygen dependency in the initial phase for a couple of weeks. These are the patients who get hospitalized. But 5% of the patients get hospitalized and they develop oxygen dependency in the initial phase. They may need some oxygen mask, some need NRB, some need NIV, some go on for a ventilator and they recover. Some need oxygen for a long time but ultimately recover. Some develop fibrosis-like features needing oxygen for a longer period. And they also make us think of lung transplantation. We did think of transplantation in one or two patients in our series. Fortunately, this subgroup of patients which need lung transplantation is relatively less because we realize that COVID behaves like bronchopneumonia, wherein the fibrosis occurs and the fibrosis heals, and the fibrosis does not progress to other regions like it happens in idiopathic pulmonary fibrosis. The fibrosis that spreads and behaves like an ILD is relatively far and less in most of these patients. So the problem that one faces are what we should ask ourselves is what are the medium and long-term COVID-19 problems of COVID-19 infection? Appearance of thrombus in the lungs is one of the major problems which one faces, which you can diagnose with our D-dimers, or if you have an access for a CT angiogram or a PE protocols, you can just check for the thrombus and then stop it. One of the biggest problems which can occur is in the beginning or during the course of the illness or even after the patient. So we have had 2 or 3 patients who have been discharged with COVID and they come back with a thrombopulmonary embolism-like features and for which they are on treatment for that. And lung becomes dry. It's a Zika syndrome after COVID pneumonia. So dry cough is a presentation, common presentation along with dyspnea. So this is one of the most common symptoms which the patient can keep coming back to. We many times think that these patients have some kind of a psychological problem. Actually, it is not a psychological problem. It's actually, as I said, is a kind of an immunological problem from virus to immunological. That's one of the reasons why I personally feel that we should start checking for IL-6 levels after the patient is discharged. Actually, we started this. I started this kind of a study in my patients who comes back with symptoms, and when I do these IL-6 tests, I find them elevated. Some of the researchers think that the IL-6, the IL-1, and IL-8 should be done more frequently than is being done now. There is a over-reliance on non-specific markers like the CRPs and the ferritin levels and the LDH levels. I think one should do it more frequently in the post-COVID scenario. One need to look at IL-6 because that can make us decide on whether they need steroids or they need anti-fibrotic drugs on a long-term basis. So what is the incidence of long-term consequences of COVID? Honestly, if you ask me, data is available. That's probably because we are just into 5 months or 6 months of it actually. Cases which we think are going to turn into fibrosis, when you see an extensive disease, extensive lung disease, you think they might go on to develop fibrosis. They do very well. And some patients who do not have any findings at all on day one, you send them on a home quarantine, they come back to you with symptoms with extensive pulmonary data. Actually, we do not have any data as such. It will take another 6 months or 7 months for us to come with data on the incidence of fibrosis that's occurring in these patients who have developed this COVID pneumonias. If you look at other viruses like swine flu and MERS, the predictions have proven to be wrong. So if you look at the SARS, for example, which came in 2003, there were some papers on the occurrence of fibrosis in this patient, but those diseases, SARS and this were very fastly controlled before they turned into an epidemic. But SARS, if they followed up, there were some papers on SARS infections in Hong Kong where they found that they did find some interstitial lung disease-like features, and there was a fall in diffusion capacity in some of these patients. Similarly, MERS also, they did find, and they said the prediction was that 30% of the people would develop fibrosis, but no papers came up to that supporting this data that 30% of the patients who had MERS developed that fibrosis, which means for this disease, we need some more time for us to get into that. I think it honestly could take about another 6 to 9 months. We're now into the 7th month now. Another 1 or 2 months it will take for us to say who are the patients. Because as I tell you, we have followed up these patients who have developed fibrosis, that is patients who needed ventilator support and who needed tracheostomy. And after tracheostomy, they were dependent on oxygen for a long period. It's 2 to 3 months now. They're coming off the tracheostomy. They're coming off the oxygen. These things are getting back to normalcy, which means what we thought as fibrosis, which is going to persist with them, it started resolving like it happens in bronchopneumonia, where it takes a long time. The radiological resolution takes a longer time, but the clinical resolution becomes much better and they start developing faster. So to classify them, I'm going to talk about these lung problems. We can divide them into parenchymal problems. There could be airway problems, or there could be pleural problems. So the parenchymal problems could be, they come back as passive opacities. After we discharge them, you see them with minimal opacities, and they come back to you saying that we are breathless and coughing. I must tell you, COVID is one of the diseases where we are doing a lot of CT scans. Patients are willing to get a CT scan even on a daily basis, and they do not mind spending money on drugs. They do not mind spending money on investigations. So we are picking up a lot of data with regards to the resolution of opacities, development of fibrosis, resolution of fibrosis. They can present as dense consolidation. When it started, we used to think that it's only ground glass opacity that's extremely diagnostic, peripheral banding that's very diagnostic of COVID. But now COVID has a protein. It's like becoming like tuberculosis. Like you say, TB can present in any manner. COVID can present in any manner. It can be a patchy opacity, it can be a dense consolidation, it can be extensive GGO, patchy opacities, progressing to extensive opacities, progressing on to fibrosis. And especially if the patients have pre-existing ILDs, CTDs, or CTD ILDs, or IPF and immunosuppressants, patients on radiation fibrosis and malignancy, when they develop fever and patchy opacity, it's quite difficult to diagnose, but there we need to have a high index of suspicion. And these patients, when they develop fibrosis, post-COVID problems in this CTD, ILDs, and ILDs is much worse in these patients. Just to show you some of these CTs, the patients can present. So there could be a ground glass like this, could be a blotchy opacities like that in peripheries, and it could present like a thin opacities in the peripheral regions, and you could also have extensive fibrosis like we are seeing in these patients. Fortunately, as I tell you, we have not seen much of a severe fibrosis in these patients. Only in 2 or 3 patients we found where we thought maybe transplantation would be a good option, where we were thinking of as a bridge. We thought of a heart lung machine, we thought, and then things started worsening, it started getting better. So this, as I said, the subgroup of patients who go on to develop this kind of a fibrosis is fortunately very rare, and majority of the people are the people who start responding to them. But as I said, the symptoms go on for 5 to 6 months time, and it will take some time for us to learn about this. And the airway problems are worsening of the pre-existing airway problems like COPD, asthma, and bronchiectasis. At the start of the COVID pandemic, we used to say that COVID is relatively rare in patients with COPD, asthma, and tuberculosis, where they have a pre-existing respiratory illness is relatively rare. But it's not happening like that. People with pre-existing illness, when they develop COVID, their problems worsen after that. And similarly, patients are developing reactive airway diseases, syndromes in people who have a pre, that is people who are not asthmatics at all, but there's a strong family history of asthma, where the tendency to develop asthma is there. In them, in the COVID developed, it became what we used to call in our olden days as intrinsic asthma, that is something has precipitated an underlying disease process. And new onset rares in smokers and non-smokers also is one of them, which means these patients go on to use inhalers and things they may start using them on a regular basis. Pleural effusions, not much data on this. We had 2 patients with bilateral pleural effusion in our last 5-month series. And pneumothorax and pneumocongestion develops, the mortality is pretty high. So investigations which we can rely on is, I keep telling, IL-6 and D-dimers are the most important investigations, in my opinion. The other investigations are non-specific markers like LDH, ferritin, CRP, PCT. IL-6 is very good, and some are also testing for some. I was talking to one of my colleagues in US. They say we are checking for IL-6, IL-1, and IL-8, which are very, very important in the COVID myalgias, post-COVID myalgias, fatigues, brain fog syndromes, leg pains, joint pains. In such situations, if you look at this IL-6, and if the IL-6 is elevated in the post-COVID phase, there is more a case for starting these patients on longer dose of longer period of steroids rather than starting them only on these antifibrotics. Even antifibrotic drugs also are becoming a very big debate whether we need to treat all these patients with antifibrotic. There was a time when I was very aggressively treating all these patients after 3 or 4 weeks of things with Perfinex or and this nintedanib fibrosis from occurring. But as we are realizing, within a month, most of these patients were started on pirfenidone and did not need them after a month's time because their CT scan started clearing, which means it's behaving like a bronchopneumonia-like fibrosis or a pneumonia-like fibrosis, where ultimately the shadow disappears and the whole thing gets back to normalcy in a matter of 5 to 6 months' time. So the reliance on IL-6 is much more important in the post-COVID phase. Radiologically, we can check for HRCT chest and the contrast CT chest and venous Doppler studies to look for any thrombotic phenomena. And the treatment that we offer to these patients is inhalers if the patient has developed RATS or if the patient is an asthmatic, start them on inhalers, the steroid-based inhalers, or bronchodilators and mucolytics, anticoagulants if you suspect D-dimer that's elevated or you have found radiological evidence of a thrombus. Corticosteroids will become the mainstay in the management of treatment. As I say, if you are going to check more and more of the interleukins, you found that it is an immunological mechanism rather than a fibrotic mechanism. Steroids will play a major role. Antifibrotics, yes, they would have a role if you see the fibrosis in these patients. Oxygen and lung transplantation across, of course, is a very, very rare thing, though there are anecdotal instances of patients who have been transplanted in COVID fibrosis. This is my last slide. We're still learning. Whatever I said today until now might change tomorrow too. So thank you all for your patient hearing.
Vinay, do we have Dr. Rambab?
Yeah, thank you.
Yeah.
Yeah. Thank you very much, sir. So, such a wonderful presentation, very crispy presentation on the parent relations, sir. So, now I invite Dr. Ramas for his talk on memories of the COVID. Before Dr. There is one question to Dr. Narasimhan sir. So how often you got the post-COVID dry cough, sir, and how you are treating, sir? Dr. Ram, you please share your slides, sir, in between.
Post-COVID dry cough is one of the very commonest manifestations. That divide them into two categories. The COVID that you see in the outpatient, where you think they don't need any treatment, they don't need any treatment at all. The COVID that gets admitted into the hospital, I classify them into two categories. The one that gets into an ICCU, the one that do not go to ICCU but stays in the ward and comes out of the hospital. Patients who do not go into the ICCU and non-ICU behave similarly with regards to the cough because it is a dryness of the whole respiratory system that develops in COVID, and these patients need to be started on expectorants. Ideally speaking, they should be avoided these cough suppressants. You should not give them a cough suppressant because cough suppressant causes a rebound cough in this patient. Though it is only a symptomatic relief, you need to give them a expectorant syrup. But what's most important, this cough is because of this bronchospasm that results in these patients. And this bronchospasm has to be treated with the inhalers, which are very important and which help these patients to a larger extent than than a reliance only on the cough syrups.
Thank you, sir. So, Dr. Ram, are you ready?
Can I speak after Dr. Prabhu so that I'm going to be speaking on the follow-up, so that will mend with being the last speaker, if that's okay.
Yeah. Definitely. So, may I invite Dr. Prabhu, MD hematologist from the Chennai Apollo. So he will be speaking on the COVID and the post-COVID vascular complications. Dr. Prabhu? Yeah, you please share your screen.
Yeah, just a minute. I'll just share my screen. Yeah, can everyone see the screen?
Yes, it is visible. Dr. Prabhu, can you put it to full screen view to your bottom right?
Yeah.
Slideshow mode.
Okay. Thank you, everyone, for firstly, thank you, Dr. Rambabu, for inviting me to give this talk. And it's indeed a great privilege to be addressing so many eminent doctors from Andhra Pradesh. The topic given to me was basically the theme of today's afternoon was COVID-19 infection and its sequelae. And as Dr. Narasimhan was invited, I thought I'll stick to pulmonary sequelae, mainly confining myself to coagulation and pulmonary vessels related complications. So I just thought I'll just divide this talk into three main categories. One is COVID coagulopathy, because we know that coagulopathy has got a huge implication in pulmonary complication, including vascular thrombosis and its sequelae. And of course, there is an interplay between coagulation cascade and the immunological processes within the lung, which results in this immunothrombosis, which is considered to be a very important pathogenetic mechanism in pulmonary sequelae. And also, if there's any implication of COVID infection for future pulmonary vascular disease, just like Dr. Narasimhan was talking about future fibrotic pulmonary disease, does this COVID infection, does it have a potential to cause a lot of pulmonary hypertension in the near future? So these are the main categories that I thought I'll talk about. So we all know that there is a unique hemostatic abnormality seen in COVID-19 infection. This is very distinct from DIC or thrombotic microangiopathy. Having said that, when COVID-19 infection becomes very severe, they do develop DIC, but initial manifestation is a very distinct hemostatic abnormality, which has been given the title of CAHA, COVID-associated hemostatic abnormality. Let's look at what it might be. So CAHA is not a typical DIC in the sense that thrombocytopenia is at best moderate, fibrinogen levels. So you want me to just give me 1 second?
Yeah.
I'll just,
So Dr. Prabhu, if I may guide you, please click on that enable editing button. That will enable you to, on your screen, there's a button called enable editing. That's what we can see actually. Maybe you're at a different place in the ID interface with you. Yeah.
Sorry. Yeah, can you, is it better now?
No, we are not able to see the presentation at all. Doctor, you may open it separately in your desktop and then click on share screen button. You can keep that open, then click on share screen, so it will be easy.
Prabhugar, please click on share screen, which is in green color at the middle bottom.
Yes, doctor, now it is
Yeah.
visible.
Yeah,
Yeah,
is it, I'm
great.
terribly sorry. Okay, we'll
That's wonderful.
try and compensate for the time lost. So CAHA is not your typical DIC because thrombocytopenia is at its best moderate. You don't see very severe low platelets. In DIC, you characteristically see low fibrinogen, whereas in CAHA associated with COVID, you have high fibrinogen. D-dimer levels tend to be much higher, and the prolongation of coagulation times like prothrombin time and APTT at best tends to be modest by a few seconds. And there is a prothrombotic state that predominates. If you look at typical DIC that happens with viral and bacterial infections, you get of course, you can get a prothrombotic state, but it's mostly a bleeding state. So in very severe disease, though, you can get low platelets, low fibrinogen like DIC. So as I told you, thrombocytopenia is modest. Very rarely you see platelet count less than 50. Usually the platelet count is between 100 to 150,000. And the prothrombin time again is just mildly prolonged by 2 or 3 seconds, but subtle changes may go undetected when PT is expressed as INR. So I'll dissuade people from using INR and look at the main prothrombin time. APTT again can be mildly prolonged. One important thing I have to mention about APTT is that because of a relatively high factor VIII level in COVID-19, it doesn't reflect the effect of heparinization. So when you're giving heparin, let's say there is a situation where you have to give unfractured heparin to these patients, your APTT may not be the most reliable test to use. You'll have to use anti-10A levels. Fibrinogen, as I said, tends to go up And in fact, high fibrinogen kind of parallels with IL-6 levels. So very rarely you can see very low fibrinogen at presentation, but towards if you have a very severe COVID, if they're developing secondary DIC, at that situation you can see a low fibrinogen. Fibrinolytic abnormalities are very common in COVID-19, hence your high D dimers, even without thrombosis. So coronavirus infections are associated with a remarkable activation of the fibrinolytic system. There's inflammation-induced endothelial cell injury resulting in massive release of plasminogen activators. And because of that, there's high concentration of D dimers and fibrin degradation product in patients with severe COVID-19. So why are D dimers elevated in COVID-19? There are two reasons. One is there is systemic thrombin generation, just like with any other infection, and subsequent fibrin formation and its breakdown. But there's also an important another component, which is actually an enhanced fibrin turnover in the lung due to severe lung inflammation. So there are two reasons why the D dimers go up. That's why in COVID-19, you can have high D dimers without even any thrombosis. So if you look at various coagulation tests, in this particular slide, you'll see that PT, APTT, etc. tends to be only slightly prolonged. But if you divide them amongst non-survivors and survivors, you see that in non-survivors, the degree of prolongation is slightly higher, and the fibrinogen level tends to be higher, and the D dimer level tends to be higher. So the coagulation abnormalities do predict a poor outcome in patients with COVID-19 infection. Therefore, getting all coagulation parameters at presentation can be useful in prognosticating. So these are the coagulation laboratory characteristics. I think we went through this just with the earlier slides. In the interest of time, I'll move on. So this is an old slide. The reason to put this up is just to tell you exactly how COVID behaves, assuming that it goes through various stages. CAHA has three different stages. The very severe stage is almost like DIC when the platelet count starts dropping and your fibrinogen starts dropping, and PT, APTT is very prolonged. In the earliest stage, you have D dimer rise with a normal platelet count and normal coagulation time. This is what you see in early stages of COVID-associated hemostatic abnormalities. Of course, these stages right now, with a lot of experience with many patients, we see patients presenting at various ends of the spectrum. And of course, there are some important therapy-related questions here, which I'll come to in the end. So this is a very familiar slide from Zhu et al. In Lancet. This was the early part of the pandemic, where it was very clear that if you look at D dimers amongst survivors and non-survivors, survivors had normal D dimers throughout, but the non-survivors had a high D dimer. So D dimer at presentation and a rising D dimer does predict mortality. However, what we've learned in the last few months of the pandemic is that the D dimer at presentation may denote a poor prognostic group, but D dimer during hospital stay, it practically has very little implication. We are seeing patients developing high D dimer during hospital stay getting better, and some of them getting worse in spite of having normal D dimers. But D dimers at presentation is a useful prognosticator. So this slide says the same. If you have a normal D dimer, your curve is flat. Whereas if you have an abnormal D dimer about 2, you tend to have, patients tend to die at various lengths of hospital stay. So, of course, we have this concept of immunological parameters, immunological activity and coagulation activity in patients with COVID interplaying with each other and producing the immunothrombosis. So if you look at, along with the D dimer, you look at IL-6, IL-6 tends to go up in non-survivors. Cardiac troponin tends to go up in non-survivors. Ferritin, which is a acute phase reactant, that tends to go up. So immunological parameters and coagulation parameters, high immunological and coagulation parameters at presentation gives us an idea that this particular patient is going to do poorly. So what is this coagulation inflammation crosstalk that is being talked about a lot? So when there is a COVID infection, we have seen that COVID can affect both the vascular endothelium in the pulmonary circulation and in other circulation as well, and also the epithelium. So this infection of the vascular endothelium gives rise to an increase in mononuclear cells, and these mononuclear cells produce pro-inflammatory cytokines, which activates the tissue factor-mediated coagulation activation, and that is clot formation. But all these thrombin, fibrin, etc., have a crosstalk with inflammatory cells using toll-like receptors and PAR134, etc. And these inflammatory cells go on as a positive feedback to the pro-inflammatory cytokines, thereby causing more thrombin. So thrombin generation causes inflammation, more inflammation generates more thrombin. So it's kind of a vicious cycle. This results in localized formation of thrombin in pulmonary microcirculation, causing immunothrombosis. So this again illustrates the same concept of immunothrombosis. So this is again this concept of thromboinflammation. So where you've got coagulation and immunological processes collaborating with each other to produce the immunothrombus. But one thing I want to make clear with this particular slide is that this is not a new concept. This is a concept that's been there for quite a long time. And it's not unique to COVID infection. It can be seen in sepsis and other viral infection, antiphospholipid antibody syndrome, and several other inflammatory conditions. But in COVID, like we know, COVID's been the most studied disease or infection ever in our history. So we are kind of finding a lot about COVID than other infection. This is not unique to COVID infection. So what happens when the virus enters into the lung? The virus enters the pneumocytes and the endothelial cells through ACE2 receptors, and there's activation of endothelial cells, which is the primary driver for complication of thrombosis. This immune dysregulation initiated by pyroptosis, which is a pro-inflammatory form of apoptosis, results in rapid viral replication, releasing massive amount of inflammatory mediators and inflammatory cytokines. These activate complements and results in a prothrombotic state by expressing tissue factor and producing more thrombin. Like we saw in the last slide, it's a vicious cycle. So this again is the slide which tells you what exactly happens. See, if you look at the lung, there are two aspects for the pathology in the lung, vascular pathology in the lung. You've got a classic pulmonary embolism, which is like a embolism from a DVT or deep venous thrombosis, where it occupies the main pulmonary artery or the main branches. This can happen, but in COVID, we tend to see a lot of microvascular occlusion, and this microthrombi may be immunothrombi, and they may be contributed by vascular shunts occurring, raised pulmonary vascular resistance in the small distal vessels, or a VQ mismatch due to consolidation or due to infection within the lung parenchyma. So this again tells you what I told in the earlier slide. The virus enters the pneumocytes, there's pyroptosis, endothelial cell activation, and inflammatory vascular injury resulting in thrombin. There's downregulation of fibrinolytic pathways resulting in a prothrombotic state, and these inflammatory markers activate coagulation, and the thrombin again activates inflammation. So it's kind of a self-propagating cycle. So we know that there's increased pulmonary embolism in COVID-19 patients. So what are the causes for the increased pulmonary embolism? One is this intense endothelial inflammation leading to in situ thrombosis, including microvascular thrombosis. And you also have altered pulmonary blood flow in response to the various parenchymal process, resulting in stagnation and thrombosis. But also there is classic DVT to pulmonary embolism transition. But I'm sure there are many pulmonologists in this audience. I think most of us have seen very little of classic PE and more of this endothelial inflammation resulting in small vessel thrombosis. So what is the incidence of venous and arterial thromboembolic events? With the increasing length of follow-up in the ICU, you tend to have a higher cumulative incidence of venous thrombosis. This is well documented in COVID, more so than any other infection. And if you look at ICU and non-ICU patients, in non-ICU patients, the increased thrombosis kind of stabilizes, but in the ICU patients, you carry on having an increasing incidence of thrombosis with increasing days of stay in the ICU. So there have been many cohort studies in COVID-19 in ICU. This is from Clark et al. And Hens et al. These are the first few people who started reporting that the incidence of thrombosis, mainly venous thromboembolism, some arterial, is as high as 42.6% or even 31% at 7 days. This is extraordinarily high degree of thrombosis noticed in patients admitted to ICU. And what they also found was that this thrombosis was occurring in spite of patients receiving standard thromboprophylaxis. If you look at the study from France, by Helms et al., 100% of patients received thromboprophylaxis, but still there was a very high incidence of thrombosis within the ICU. So this is again more studies which tells you that there is a lot of venous thromboembolism. I think what we have to take home from these two slides is that there is most definitely an increased incidence of thrombosis. The exact rate is very difficult to determine because some studies they've been very proactive in looking for thrombosis, and some studies it's been mainly clinical observations. So this again, this slide illustrates basically the incidence of thrombosis within patients with COVID-19. If you look at the percentage, there are some studies which have shown 40% and some as low as 5 or 6%. So, but I'm sure a lot of clinicians who treat COVID in this gathering and elsewhere most of them agree that this is uniquely prothrombotic. Of course, all infections are prothrombotic. This is probably more prothrombotic than the earlier infections that we have encountered with. And this is again, incidence of pulmonary embolism in various studies. So there's definitely an increased incidence of pulmonary embolism. So if you look at this again an old slide, but more or less this is what is our experience even recently. If you look at central pulmonary embolism and lobar pulmonary embolism, they are relatively rare. But if you look at segmental and subsegmental PEs, they are more common. DVTs are less common. So this again draws us to the fact that maybe most of these clots that you're seeing is localized immunothrombosis. And again, there's another therapeutic question to think about. Are we addressing this by heparin or not? So this slide tells you that most of the thrombosis happens in the smaller circulation. So, of course, GGOs are common in COVID-19 pneumonias. And in fact, as Dr. Narasimhan was alluding to, now CT scan has become a standard diagnostic procedure with COVID-19. And if you have bibasal GGOs with the typical symptoms, you're almost certain that it is COVID-19, even if your PCR is negative. So what are these GGOs? GGOs are just parenchymal inflammatory change, but if you look at some studies, they've shown that these GGOs represent more than just parenchymal change. There's focal vessel enlargement, there's regionally dilated segmental and subsegmental pulmonary vessels, there's increased branching and tortuosity of pulmonary vasculature, and there are perfusion abnormalities seen on dual energy CT. So the ground glass abnormality is parenchymal abnormality due to infection due to COVID-19, but it also has several vascular abnormalities which we also have to pay attention to. So this slide, if you look at the first panel A, it's a ground glass opacity within which there are some subsegmental dilated pulmonary vessels, and also there are some distal subsegmental pulmonary vessels which are engorged and tortuous. So there is a vascular abnormality within this parenchymal infiltration. So the vascular change is probably if not equally important, it's something that we need to keep in mind. So there is vascular injury leading to abnormal vasoregulation and vascular shunting. Maybe one explanation for the presence of hypoxemia that is disproportionate to the reduction in pulmonary compliance in some patients with COVID-19 pneumonia. I'm just quoting from an article. So we know that in some patients with ARDS due to COVID-19 pneumonia, the pulmonary compliance is not reduced, it's maintained. So in them, the hypoxia is probably due to vascular shunting is what some people propose. So this vascular problem within COVID lung is well illustrated by this particular article that I found on looking up yesterday. So if you look at a healthy lung, the red color represents the small vessels, yellow the mid-sized vessels, and blue are the larger vessels. If you look at COVID-19, there is hardly any blood in the red. There is no red at all. So which means there's hardly any blood left in the distal vessels, which means that the immunothrombosis or the thrombotic manifestation in all the small vessels in the lung is very dominant. So there is apparently a significant correlation between histopathological markers of this vascular pruning that we see and CT-derived markers of pulmonary blood loss in the smallest caliber vessels. The reason to put this slide, of course, it may not be relevant clinically in the sense we're not going to end up doing these studies, but just to kind of highlight the fact that there is a significant amount of vascular redistribution from the small vessels to the larger vessels. So hypoxia in the context of preserved lung compliance with SARS-2 COVID-2 infection is almost considered to be an infectious mimic of idiopathic pulmonary hypertension. The reason to talk about this is, of course, it's too early to see what develops in these patients after a few months or year down the line. but some patients may develop pulmonary hypertension in the future. So this again is quite a complicated slide, but this is what it tells you is that for the distal vessels, there's hypoxic vasoconstriction, the cytokine storm causes some vasoconstriction, there's mitochondrial dysfunction, and there's also oxidative stress and DNA damage causing almost a pulmonary hypertension like pathological situation. So this again is another interesting article from Respiratory Medicine. They found that all these opacifications that you see in ARDS, that is an important component of pulmonary artery thrombi. Thereby emphasizing that this thrombosis in the small vessel is a very important part of COVID infection. So COVID-19 infection in pulmonary vessels, again, I'll just very quickly talk through this slide. This just tells you that in acute coronavirus infection, there's quite a lot of strain on pulmonary hemodynamics due to myocarditis, myocardial injury, and also due to this, the pulmonary vasoconstriction in the smaller vessels. So just to illustrate this point, of course, today's afternoon is all about vascular sequelae, pulmonary vascular sequelae in COVID-19. So I just thought I'll put some slides up from this very remarkable study, pathological study, which was published in May or June. So if you look at COVID lung, there's a lot of lymphocytic inflammation, and there are some microthrombi seen in intraalveolar small vessels in the intraalveolar septi. So this is the first pathological proof for this microthrombi in the small vessel. And if you look at this slide, this is again well known to a lot of people. It appeared in the New England Journal of Medicine. It's kind of very, I don't know if it projects very well. So panel A, it's not projecting very well. What this slide shows is that there is direct involvement of the endothelium by virions. And if you look at new vessel formation, intersusceptive angiogenic features, it's much higher in COVID than in similar H1N1 pneumonia. So there is this strong vascular component in COVID that one has to keep in mind. And there's a more recent article in Nature Pathology. I think this tells you about there's a gross lung where there's a lot of thrombus in the arteries, and also there's microscopically demonstrated thrombus in small and big vessels. So it's a thrombotic disease along with an inflammatory disease. And if you look at, there was one study looking at pulmonary hypertension, similarities between COVID-19 and pulmonary hypertension. This is fairly an elaborate slide with a lot of parameters to look at. But the general feeling I got after looking at that slide is that there is a concern that patients may develop pulmonary hypertension in the future because some of the pathogenetic mechanism is very similar to primary pulmonary hypertension. So can COVID-19 be a risk factor for subsequent pulmonary vascular dysfunction? Yes, maybe. Survivors of severe COVID-19 are expected to experience persistent impairment in lung diffusing capacity and gas exchanges. And this impaired diffusing capacity may be partly of vascular origin. One of my pulmonology colleagues here said that sometimes they see low DLCO, although there is not much fibrosis. Maybe that is of vascular origin. And COVID-19 infection could be a risk factor for persistent pulmonary vascular defect and subsequent pulmonary hypertension development. So this is something we have to be very aware of. So I think what I've done this afternoon is just to go through what are the vascular complications seen in COVID pertaining to the pulmonary vasculature. Of course, we are seeing a lot of DVTs, PEs, etc. Other vascular thrombosis as well. Being a hematologist, I thought it would be useful just to give a basic guideline as to what we do with coagulation prophylaxis, meaning anticoagulation prophylaxis and treatment in COVID-19. This is a very simple slide. More or less, this slide I made nearly about 3 months ago, it still stands to scrutiny today. So all inpatients, in terms of coagulation tests, I think anybody who's sick enough to come to hospital should have the basic coagulation test at presentation because there is a prognostic component to that. Now, venous thromboembolism prophylaxis. All patients admitted to the ward should have standard VTE prophylaxis. When you say standard VTE prophylaxis, in a standard person, 70 kg man, a 40 milligram subcutaneous Clexane is probably the right dose. But if you're a heavier person, you have to go close enough to 1 milligram per kilogram body weight or a 60 milligram dose. So all patients admitted to ward with COVID-19 infection should have standard thromboprophylaxis. Very importantly, don't be put off by moderate thrombocytopenia and prolongation of PT, PTT, etc. See, we have had patients with platelet count of 30, 40,000 where we have given standard thromboprophylaxis. A mildly prolonged PT, APTT, etc. should not dissuade you from giving standard thromboprophylaxis. Of course, if there is gross prolongation and there is DIC, then that's a different matter altogether. Now we come to the more difficult areas for thromboprophylaxis. So if you look at patients who are transferred from the ward to ICU or directly admitted to the ICU, there you have a reason to consider escalated dose VTE prophylaxis. This is a very controversial area. If you look at the earlier slides, we saw that patients who had standard thromboprophylaxis in the ward went ahead and developed VTE while in CCU, while in critical care unit. So people thought, it'd be silly to do the same thing when you're seeing such an increased rate and they increase the dose. But there is no clear evidence that there are randomized controlled trial in progression as we speak. But this whole area is very divided amongst experts. Some people believe that's the right thing to do. Some people say we should just continue the standard dose of thromboprophylaxis. I would say in a patient shifted from a ward to ICU, I would say go for a intermediate dose prophylaxis. Like for example, 40 milligrams subcut BD of Clexane or a 1 milligram per kilogram body weight of venous of enoxaparin. So definitely there's a reason to increase VTE prophylaxis. But one thing I would dissuade is to use treatment dose low molecular weight heparin unless there is a radiological evidence of PE or DVT or there's a strong clinical evidence, because there are some places where they do use, they have a very low threshold to start treatment dose, but you have to be very careful. You may end up with a lot of bleeding manifestations. Now, therapeutic dose anticoagulation, of course, we know in confirmed VTE and confirmed PE or in presumed PE, where suddenly oxygenation becomes difficult. You can't shift the patient down for CTPA. There are other causes which you have ruled out. Then you can start putting them on treatment dose of anticoagulant. That leaves out a very important, more controversial area. It is patients discharged from hospital when they go to the community. What should you do? Of course, medically ill patients leaving hospital, there is an increased risk of thrombosis for at least 6 to 8 weeks after their discharge. And there are many trials that involve medically ill patients being given thromboprophylaxis. And if you look at the various trials, you'll see that the benefit is marginal if you do in all patients, but if you select out certain patients, then the benefit is considerable. There's also a bleeding risk. So there are certain scores that you can use called Prevent VTE with D-dimers to decide on whether they go home on anticoagulation. And the anticoagulant you would use is low molecular weight heparin like Clexane, 40 milligrams subcut P once a day, or a newer anticoagulant like rivaroxaban 10 milligram OD. Duration, again, very controversial. It can be anywhere from 2 weeks to 4 weeks. If you look at various hospitals, whether in India or abroad, different hematological concerns, different hematologists or different critical care physicians use different strategies. So this more or less concludes. In fact, this concludes my talk. I'm willing to take questions.
Dr. Rambabu? Yeah, Dr. Rambabu, you had gone on mute.
Thank you, Vinay. Unmute. Yeah. Now unmute. Thank you very much, Prabhu sir. So excellent lecture. So now I invite Dr. Ramas sir to share his screen. Before he finishes his screening is sharing, can I ask one question to the Dr. Prabhu?
Yes, sir.
What is any post-COVID fatigue or weakness? So how we are managing, sir? So how long? So you want to see that? Whether it is somebody says that it's a 6 weeks or the 8 weeks, or like that we have to wait, or you want to give any specific treatment to him?
So unfortunately, see, I look after COVID patients mainly when they've got hematological issues, and I advise on thromboprophylaxis, etc.
Okay, okay,
I don't do.
okay,
I mean, I'm of course. I have no idea about.
Yeah, Dr. Yeah, Dr. Narasimhan sir. Narasimhan is unmuted. Vinay?
Yeah, Rambabu, what was the question you said?
Post-COVID fatigue, how long it will persisting? So, can we wait to 6 weeks or the 8 weeks mark? Then we have to give any treatment, or otherwise it's a normal only. We have to leave them like that.
Yeah, there are two things in post-COVID myalgias. In the post-COVID myalgia is explained to be an immunological mechanism wherein giving a painkiller for a long period is not a good idea. We tell them to go on exercises. How long would it stay?
Yeah,
I don't think anyone knows about it. There are no data on that. How long does it stay? As I said, it will take about another 5 to 6 months for us to come out with real-time data on the post-COVID myalgia problems, post-COVID fatigue problems, the brain fog syndromes with the people who are experiencing. It will take some time for us to get into that. But until such time, I think if in all these patients, I personally feel we need to have a data on these IL-6 and D-dimer levels. And if the IL-6 levels is elevated, you will be much better off with the low-dose steroid. There is a case for adding steroids in these patients of high IL-6 with fatigue syndromes, which so there are some muscle activating drugs are available. Those things can be added to that. The time limit, how long do we continue? I don't think there is any such time limit, and we keep continuing that as long as they have these symptoms in a low dose. But one of the problems which most of us are facing now with COVID, post-COVID phase is the number of diabetics is on the rise actually. That's what we notice in the as a clinician, I'm noticing that a lot of people who have been started on steroids, especially the Dexa that we start them on for the 10 days, and then we maintain them with these steroids, they tend to develop diabetics. And more diabetics will come in maybe another 1 or 2 years' time. The diabetic population is definitely going to be on the rise.
Can you all see my screen
Yes, Dr. Ram,
Yeah.
your screen is
on the? Okay. Before I start, is everybody ready? It's a long process. So do they want to empty their bladders or bowels, or nicotine, tea, coffee, something like that? Or should I wait for 5 minutes, or can I start off?
we are good to start, Dr. Matsa. Please go ahead.
Thank you very much. And it's my privilege to speak to you all. And thank you very much, Dr. Rambabu, and all the distinguished speakers who spoke before me. Sometimes it's overwhelming when a lot of science is going on. Now, I have to keep it very simple, and I'm going to be talking on a COVID sequelae, our real-time experience, if that makes sense to you. So I am the chair and the lead for the critical care follow-up and rehabilitation with a specific focus on COVID. And I also lead the strategic sepsis committee within our hospital, and therefore that's my kind of a focus. So this is where I work, and that particular area is the critical care department. We have a helicopters kind of bring the patients across, and straight away we get them into the intensive care and look after them. And it's quite not a bad place to work, to be fair. And also our city houses the Stoke City Football Club, and obviously we're out of the Premier Club, to kind of not annotate where I'm working at this point of time. We at one point of time, we were looking after about 90 ventilated patients. That was the hit of the COVID patients. So literally every day, and we have to work for about 53 days, non-stop continuous. So therefore, a reasonably rich experience of what we have had over the intensive care patients on the COVID. So I am going to be speaking to you on the sequel of the COVID patients who have been in the intensive care. Now, the problem is big. The problem is really, really big when you think about the sequel of the COVID. The COVID is a problem, yes, we do understand. And worldwide, you can see about nearly 43 million patients have been affected with that, and nearly about 30 million have been recovered. The reason why I'm saying it's a problem is it's good news that they've recovered, but what are their needs who is recovered? And what exactly are we anticipating they to do? Would they go back to work the same way, or would they be having to come back to hospital often? Would there be any kind of sequel that kind of follows on the COVID illnesses? Much more in India is because of the process that we have in India is quite significant amount of patients who've been recovered, about 7.14 million, and the healthcare sector should be in a position to provide and support that recovered kind of a patients. And more interestingly, Andhra Pradesh has done very well in terms of your death rate is significantly lower when compared to the other states in comparison, despite the fact that you have the highest amount of one of the highest amount of the COVID patients, and the recovery rate is significantly high. That imposes a problem, basically. Now, if you look at the disease pattern as such, we have the common things that do happen within our kind of things is the mild disease, which is quite common, and who do develop mild or no pneumonia. Their needs clearly are unclear, but may need a further kind of intervention in the follow-up. But most often what I am dealing with is the severe and the critically ill patients, as it's been classified as the patients who have more than 50% of lung involvement, as well as those with the ARDS. And majority of them do require significant long-term moderate to severe deficits. And therefore, there is some kind of a needs for them to be associated after they have left the hospital. And now, if you look at this as a problem, we have a few questions that's unanswered. And because we are speculating, we are seriously speculating, because the evidence is not clear, because we're too early into coming up with the kind of research processes. Yes, we are identifying the treatments, but I'm not too sure what we're facing, what exactly are the long-term complications. And what to expect is in the sequel, because every other patient is different. What we're seeing is the tip of the iceberg. And also, I'm not too sure what is the course of the disease. Is it like a TB, which will reactivate at later time? Or is it like a chicken pox, where people will have other complications secondary to the same thing, which is a primary infection? None of us are very clear about this kind of. This is why we call the COVID a multi-system disease. Now, once upon a time, when you talk about the tuberculosis, if you know tuberculosis, you know the rest of the system. Very similarly, the syphilis. And now they talked about other viral illnesses. Now, similarly, the COVID is a multi-system disease. It can affect the lungs, the brain, the heart, kidneys, gut, skin, etc. Now, we have eminent speakers did speak about the thromboembolic phenomenon, and as well as the kind of lungs. I'm going to be not touching those kind of aspects of it. Now, this has led to the evidence accumulating. So people wanted to know about so many things. What are the other manifestations apart from pneumonia? Which is why the research is still in the bay, and lots of evidences has been generating as every day goes by into looking into the other manifestations of the COVID disease. Now, I'm going to start off with a real-time journey of a patient. I'm going to not disclose the names and everything. It's just to kind of see what really happened. We have to deal with a 57-year-old school headmaster, reasonably obese, and he has a type 2 diabetes mellitus and hypertension. Not too bad, and fit well to that kind of an age, who presented to us about 4 days of worsening cough and shortness of breath and loose stools. He has a classical anosmia prior to that. Not very good. Admission saturations were 88%. And the CT scan, the imaging showed a clear evidence of ground glass opacities. As you can really see, it's a stereotype of what you call it as a COVID pneumonia. We did treat him. It started off with a non-invasive ventilation, and then we have to prone him, unfortunately, and he had the appropriate kind of treatment. That's me. Obviously, we have to, he recovered quite effectively on day 14. and he went home, all flowers raging and things like that. So it was a happy moment on the day 21 for this kind of a patient, despite the fact that he had a turbulent time and he went home. What was happening after that is quite significantly disturbing. This patient had still going on with shortness of breath. He was not able to get back to his work, not able to be working as a headmaster, not able to do the simple arithmetic, has been having memory loss. And as Dr. Narasimhan has alluded earlier, he was suffering from significant fatigue. He's not able to do the work and walk the usual kind of dog walking as it is. So he has had multiple general practice visits. And every time they go, they do test for a COVID and reassure the patient. And unfortunately, nobody knows what the diagnosis is. So for him, he's been treated COVID patient, successfully treated COVID patient. And he should, the contrary to be happy, he's still bad and depression. He was unfortunately started back on antidepressive medications. This is not very uncommon. Unfortunately, we have to see him back in the hospital with a florid pulmonary edema, acute confusional state, back in the hospital again. Although we thought we did very well on the COVID, we didn't we? So what is this problem? Is this a post-COVID sequelae, what we are now diagnosing as a long COVID syndrome? Is there a way that we could prevent it? Did we make a mistake by not following up these kind of patients? These are questions that immediately have to occur to one of us. And which is why we have started a follow-up of these kind of patients based on certain kind of aspects of it. Therefore, my topic today, as I just to introduce, it's the importance of the follow-up of the COVID sequelae. Now, for you to follow up, you not kind of have to draw a big fish net on a big sea and catch all the fishes that's possible. You need to have a clue for what you are looking at. Now, the problems I identified, the philosophy of medicine is very clear. The problem is not about identification of the poor patient of the COVID. I don't think so. It requires a rocket science, and it's very easy. But what we are facing as a problem is who on earth is going to be deteriorating quite quickly to a severe COVID and the prediction tool. And that's now any one of us can develop that. That'll be a Nobel Prize. We haven't got that kind of an answer to it. I'm not going to speak about this. Perhaps in a later day, if I get another opportunity, I can talk about prediction tools we are using at the moment. Also, my importance as a follow-up clinician and the intensivist, the patients coming to the intensive care who have had a severe COVID disease, how are many of them and which of these will develop a long COVID syndrome? Or who could be another headmaster who came up to us and the kind of things? Is there any way to prevent it? Now, this is very important. This is what I learned in my earlier years of medicine. I'm sure Professor Rajendran is there, C. Rajendran, who is the person who kind of taught me to do this. So the concept of the disease is very clear. It never changes, whatever the disease that you are going to be dealing with. First thing is you need to identify the disease. Once you identify, you need to start preventing the progression if possible. Now, obviously, we need to have a definitive management. Unfortunately, for the COVID disease, we don't have one. And more importantly, if they get treated for some reason, we need to prevent the complications. Now, the million-dollar question is, how to prevent the complications? You need to be aware of what complications a patient who's coming into the hospital is going to develop. And what we need to do is, therefore, we need to develop an association factors. And that really is important for us to just kind of get to the start. From start, as Dr. Narasimhan has alluded to, there was a big study, which is a symptom study, which is done by CAFI, which is one of the earliest publications in the JAMA. We identified some of the symptoms the patient do feel before they came in last longer: fatigue, anosmia, joint pain, and dyspnea. So there are some kind of a symptoms, which kind of things, which means that there are some aspects which kind of follows up, and eventually it kind of goes off. Now, again, I need to reiterate, it's a multi-organ system problem. So where to start? Therefore, I'm going to be linking in the extrapulmonary manifestations limited to COVID. So I said limited to because we have had a professor of pulmonology, Dr. Narasimhan, has spoken about the pulmonary. There's no point of me discussing the same kind of thing. And similarly, a very eloquent talk was delivered by Dr. Prabhu on thromboembolic manifestations. So I'm not going to be dealing with. I'm going to be looking into the commonest kind of a manifestation, the cardiac and neuropsychiatric, and much alluded critical care related kind of manifestations. And therefore, we'll just kind of get a template across to what are the things that you look forward in a patient who's discharged from your hospital with a COVID disease and which you need to be following it on. Let me start from the cardiac. The most common syndromic approach of cardiac, this thing, which they present with in the COVID, is myocardial injury. The myocardial injury can be because of your thromboembolic phenomenon, inflammatory myocarditis, usually panmyocarditis or endocarditis. They have a significant myocardial injury, therefore they're present. Or arrhythmias can be because of the primary myocardial injury or secondary to the drugs that we are giving these kind of patients, especially the hydrochloroquine is notorious, and we stop using them anymore. And also the patients do develop sudden cardiac. We now have an answer to the sudden cardiac death in the research is because of the significant pulmonary hypertension they develop and the right heart failure leading on to these sudden cardiac death, much more common in the younger individuals with young hearts, if that makes sense to you. So now the reason why I'm just kind of talking about is if the patient comes with these, they have a sequel to follow. And for us to understand the mechanism behind it, everybody knows about the, I'm sure everybody knows about the entry point of the SARS-CoV disease is your ACE receptors, right? Which is much more abundant in a cardiac myocyte. Right, and these are the lollipops. They are the surface proteins which kind of through which they enter, and therefore they kind of regain the release of this COVID. So the damage which is caused is much more in the process of the viremia per se, the viral load, but most often is also because of the fact of the inflammatory cytokines that releases when the virus escapes or replicates and comes out in the kind of a processes. Therefore, although this kind of a slide looks a little bit populated, you see all this kind of a gray areas is the kind of a main focus that we need to follow. And you do get that acute coronary syndrome because of a thromboembolic manifestation due to the vasculitides as you get in any other kind of things. And they develop a macrovascular or a microvascular dysfunction and leads on to acute coronary syndrome. Now, they also have a cytokine storm because of the inflammatory, the pro-inflammatory cytokines, which are released as a result of the macrophage activation and causes myocarditis, which is unique in this kind of condition. It's purely myocarditis and not many pericardial effusions we've seen, strangely enough. It's our experience. This myocarditis also causes permanent dysfunction, which generates some kind of arrhythmias and leads on to some kind of sudden cardiac death. Now, what this illustrates us, I kind of divided this into the processes and what we need to be following it up very clearly. Now, one on the left is the processes, where you have the demand supply oxygen mismatch, either because of the profound hypoxemic state the patients are in, or because of the thromboembolic phenomenon. They might develop a STEMIs, embolic, hyperhidrogen state, which is as it would be for any kind of a hypercatabolic state. You have a microembolic infarct you've seen in the biopsies of the heart muscle. All this kind of leads on to a myocardial injury, whatever it may be. So this leads on to the 5 different subtypes you'll be looking for to follow up in the future when you come into this kind of a follow-up clinics. They develop ischemic cardiomyopathy, much more common, non-ischemic, which is because of the myocardial dysfunction secondary to the myocarditis. Subclinical systolic diastolic abnormalities, which I'm going to talk to you about it because the new syndromic approach, which is emerging as heart failure with preserved ejection fraction, which is much more common in the patients with the COVID, which is underdiagnosed. And we do have ventricular tachycardias or paroxysmal ventricular rhythms. So therefore, they lead on to sudden cardiac death, and also because the right heart failures and atrial fibrillation. Now, this is what the commonest we are seeing in the kind of outpatients clinic when the patient is being discharged. And now, this is, I would just kind of think about what has happened to our kind of patients in our intensive care before, where I kind of look carefully for what I'm looking for. This is a few examples of what we are seeing in intensive care. You do develop thromboembolic phenomena. It's a right ventricle, and you can see a thrombus in the transit from the left atrium down into the kind of ventricle, into the right atrium to the right ventricle. And there's a parasternal view. You also have a left atrial thrombus sitting there, the echocardiogram. And also you can see dilated left ventricle. It's the kind of syndromes that we see commonly, dilate because of the myocarditis. And this is our patient, which I was alluding to. He had a significantly dilated kind of a ventricle. And when we did a re-MRI on him, on the day of presentation with the patient, you can see a significant inferolateral wall gadolinium contrast that's kind of getting things through there, and that's the kind of a problem. And we would have thought maybe this could have been picked up much earlier before what has happened, whether we could just kind of do some cardiac rehabilitation in order to remodel this kind of a patient. This is a lesson we learned, and that's why we just are just kind of alluding to, see, there's an association, what the patient came in, do prompt echocardiograms during your kind of things, and get a surface area, it's a surface picture of what the heart is like before the patient has been discharged, so that you can proactively follow the patient as to what is going to be emerging, and therefore you can ideally give either antiplatelet agents or a repeat gadolinium scan, or whether you want to put the patient on certain kind of devices in order to prevent such kind of a failure in the kind of future. Now, the emerging threat in the cardiac patients who come into the COVID is what we call as a heart failure with preserved ejection fraction. These are the multiple pathogenetic mechanisms which lead on to the kind of things. What I'm going to be illustrating is not about the acute illness, which leads on to the predominant hyperinflammatory cascade, which leads on to the changes in the myocardial dilatation and the remodeling issues. However, this has a bigger effect on the long-term illnesses when it's associated with the chronic pulmonary disease, where they develop pulmonary hypertension. Left ventricular diastolic dysfunction is being maintained that way, or right ventricular dilatation and dysfunction. All these kind of things can be either because of the direct infiltration of the virus into the myocyte through the AC inhibitors, which is quite relevant now in the post-mortem studies, as well as they have identified adverse cardiac remodeling, as our patient who had an MRI, which is gadolinium contrasted MRI, showed the significant decreased gadolinium uptake, which could have been predicted much earlier for this kind of a patient, which could have potentially prevented the patient to be admitted. Now, so what am I going to do with this? We know that the patient's got this thing, and the surveillance should have to start with what the patient is presenting with, right? I can share the slides. Obviously, you can just take this as a protocols and things. So surveillance starts from there, where they had a myocardial injury, and during the convalescent phase, you proactively investigate them for these problems, and therefore you would be in a position to reconsider whether the patient could be medicated. Cardiac rehabilitation incited much earlier, so that you have a better outcome, not just the treatment of the patient. We are looking into the longitudinal outcome. I want the school headmaster go back to work as a school headmaster who can run a marathon even after having had a COVID. So that could have been prevented, is my kind of a process in here. Having seen the cardiac, let's assume what are the neurological and neuropsychiatric manifestations. Very similarly, the acute syndromes they present with in the COVID would be the cerebrovascular. These are the four common acute syndromes they present with, along with the pulmonary things. Cerebrovascular accidents, that's because of, as we alluded to, is the thromboembolic phenomenon. And sometimes not clear is they present with an altered sensorium, an acute confusional state, which is because of the viral induced cytokine storm affecting to the brain, which presents as an encephalopathy or encephalitis. You also have seizures presentation, and those affecting the peripheral nervous system, which is increasingly identified. They're present with Guillain-Barré. Things like myasthenia gravis, as well as neuropathy, is also being usually seen in this kind of a patients. Still, we're not uncovered the kind of all kind of things. So you'd have to think about the neurological, neuropsychiatric manifestation involves the central nervous system as well as the peripheral nervous system. Okay, so the important thing about the virus is not very unclear. It's all the speculation is the entry point of these kind of viruses. So there is obviously clear evidence from of the postmortem studies that there is an entry point is olfactory. It's a direct viral invasion which presents that as an anosmia and infects the CNS, and they cause all these kind of symptoms, including the encephalitis. Now, it may also be because of the cytokine storm, where these systemic dysregulation causes disruption of the blood-brain barrier, so that you have a brain-identified cytokine toxicity. And this is responsible for acute cerebrovascular diseases, including the strokes, as well as a new condition called acute hemorrhagic necrotizing encephalopathy, which is also being identified in this kind of a patients who have a lengthier, prolonged neuropsychiatric rehabilitation program. Some of our patients did have that. Now, very similarly, the pathogenetic mechanism is because of the pulmonary systemic disease. It can be because of the hyperinflammation, hypercoagulation. Usually, they're present in these things: stroke, encephalopathy, or encephalitis, right? Thromboembolic, or because of the cytokine storm. Now, what we are seeing much more commoner is the vasculitides. So the brain, when subjected to the postmortem examination, shows a clear evidence of microstrokes, which can lead on to the vasculitides and the stroke syndromes. This is also responsible for the anosmia, dysgeusia, but that kind of explains the people with a lengthier anosmia have a significant amount of viral titers, even if they have come out of the kind of things, which means there is invasion in the state. This gives us an evidence whether we're dealing with a neurotropism of this particular viruses. Now, you also what is more important for me in the follow-up is this kind of a group of patients where they have GBS, right, necrotizing encephalomyelitis, and ADEM kind of a presentation because of the immune-mediated complications. This is very common. We are seeing in the kind of follow-up kind of a patients. Sometimes after they have the COVID, they do develop these kind of a complications, and which is very prevalent in the follow-up kind of a clinics. Now, this is some of our patients. So we have seen the bleeds. Okay, it's a big bleed, and some we have strokes and stroke-like kind of a pictures. And what is very important in these, as Dr. Narasimhan has alluded to, is there's about quite a half of them, when they come back to you in the clinic who has been admitted in the intensive care, they do come with what we call as a brain fog. What is this brain fog? Is a combination of a significant cognitive dysfunction, which means they do develop inability to calculate the way they should be, and they can't walk the way they are, and there's significant amount of memory loss. They also suffer from post-traumatic stress disorder and the depression. Now, I'm going to be concentrating a little bit on the brain fog, because this patient who came in with the kind of acute confusional state did have, we suspected, biological plausibility of why this could ever happen. Now, when we did the CT of these kind of patients, most of the patients who develop this brain fog have delirium whilst they are within the kind of a hospital stay. And I'll talk about the delirium in a minute. And what we see in the brain is this kind of huge number of dots, the brain fogs, right? What exactly it is the micro infarcts that is happening in these kind of patients, typically occupying one definitive area in multiple kind of an area. Now, these are the patients you should be watched for very carefully in the follow-up, because they have a significant amount of rehabilitation that you can make for them to get back to the kind of a position where they are in. If identified earlier, better the chances, because you don't want the rest of the brain to go in for a gliosis. That makes sense to you. There is also increasing evidence whether we should be giving antiplatelets for those patients who have had to identify the cerebral microbleeds, but still the evidence is not out, and we started. When I talked about the delirium, which has a kind of direct association with the brain fog, the delirium we see in almost 80% of the patients who are in the intensive care, they develop delirium, especially with the COVID. And is it an association factor? Is it a causal factor? I do not know, because we don't do a CT scan of the brain regularly for all the patients in the intensive care. Perhaps if I have to let retrospectively, I would have thought, yes, should we be doing is to analyze whether these patients, do they have developed microinfarcts as they're trajectorizing to the kind of a forward. Now, we also have to think about the post-traumatic disorder and the anxiety depression, because in your follow-up, there is an very important place for your psychologist and a psychiatrist to play, right? Now, this is an important topic which is close to my heart, which is often underestimated, is the critical care related. And we are publishing this quite soon. And this is what we see in our kind of things. The patients who are intubated, you can see they have a significant vocal cord thickening. I'm thinking, this is my hypothesis, whether the post-COVID dyspnea is alluded to this particular phenomenon. Majority of the patients, I'm doing 4 different kind of patients, have vocal cord swelling, and this swelling quite lasts for long. If you look at this is what they are find. And there is a description in many evidences, what we call it as the laryngotracheitis that's developed specifically in COVID patients. These are all the COVID patients who have a significant swelling, which narrows the larynx significantly, and they do develop dysphonia and dysphagia because they have aspirations and everything, and that thing lasts for longer. We do not know what the reason is. Supposing if I do a MRI on this kind of a patient, there's some of a patient who develop a kind of a narrowing, and they develop a quite significant stride out, and we have to use the ENT for us to just kind of put some stent, and these develop laryngotracheal stenosis, which is one of the we identify this kind of laryngotracheal stenosis specifically in the COVID patients. And this is a patient, obviously the data is wrong, it's actually 220, it's quite recent. You can see even the larynx is not closed, and there's significant swelling even after I remove the kind of tube. There's a feast imaging of the patient. This is the larynx, that's the esophagus where the food, the nasogastric tube is running. And you see during the swallowing, ideally it should close. It's still not closing. That makes sense to you? So which means there's a significant risk of an aspiration, and that leads on to the chronic respiratory problem in this kind of a patients. This is the hypothesis. I'm not too sure, but we will be getting an answer quite soon to that. Right? There's another patient. Now, when we see all this kind of things, and we are into a question, and you're going to be putting back, how do we tackle this? Now, I'm just going to giving you a snippets. This is just the tip of the iceberg, and because of the time I have to wind things down. Now, operationalization is very important. It's not just the end, the COVID diseases. We need to make sure that we identify the at-risk groups. We need to have a modality of screening. What do you want to screen? Obviously, you cannot screen everybody for heart, lungs, thromboembolic, pulmonary. So how many you can screen? You're dealing with not 1 or 2 people. You're taking about 714 million people. This is not easy. So you need to be in a way to screen them and develop a risk stratification. Who would be developing follow-up problems? Who would develop the early care options, and how will you therefore develop a definitive care? Therefore, this has led on to us to develop this kind of a platform. This is what we do, a protocolized follow-up. So we have a pickups tool, which is the post-intensive care positional screening tool, where we have a multidisciplinary team which looks after these kind of a patient. The information gets to speech and language, psychology, occupational therapy, and we have this kind of things where I sit here, right? I lead this kind of a processes. So therefore, we identify what the kind of a problem, and uniformly we develop a rehabilitation prescription which the patient follows on. That's the patient's COVID passport, where the patient looks into these kind of things and takes on from where we're coming from. And this is my pathway, which is done in the post-intensive care. The patients who come out of the intensive care, based on the a specific identification, the discharge to the ward or the discharge to specialized rehab and acute rehab services, based on what we identify. There, once they discharge home, we see them back in the consultation and triage, and we re-see them back in about 6 weeks, where we either discharge them or we put them in the medical clinic where we do further imaging based on what we find. And also they have 4 pathways, and finally they are discharged into community follow-up, where they should be allowed for the GPs to kind of look into this kind of a process. This is a very stringent pathway which kind of isolates and identifies the ongoing kind of a problems with these patients, which is a good triage tool for everyone to kind of follow. I'm happy to share my kind of a pathways if anybody is interested. Now, it is important for you to understand the physiotherapy, where they have a chest therapy, early mobilization, modified mental scale, and all the kind of a processes we do. And it's not one person. We need to have a collective team. And we have an occupational therapy where they prevent the delirium, they goal set. And so therefore, if you're dealing with a headmaster, we need to get to goal that he has to go back and work what he do. And they ascertain the functional activities, the orientate. So this kind of occupational therapies prevent the brain fog to happen. And they also talk about all about me. This is our kind of a goal setting. We have dietetics. Similarly, we have clinical psychologists, where they do all the psychological education, cognitive behavior therapies, where the people will think. And we have a speech and language who do the FEES, which is endoscopic evaluation of the upper airways, where we identify such kind of a patients with swallowing difficulties, and we do a laryngeal wean for these kind of a patients, and communication. And also we have a rehab coordinator who puts everything together and does a rehab prescription for these kind of things along with the doctors. And we also have a psychiatrist who does various aspects, especially who deals with the PTSD and ongoing psychological manifestation along with the psychologist. So what do we do in our in-house rehabilitation? We have goal plans. This is next to the patient's boards. So they need to do all this kind of things, and we make sure they have a clear signposts, what they are feeling and everything. And therefore, the patients, when they are, even they have tube, they'll be in a position to communicate, seeing what they are kind of. There's a bedside table of these patients. Some of the patients who are recovered from the kind of COVID, who are mobilized despite the patient hasn't got tracheostomy. This young lady has been with us for about 88 days because of certain kind of degrees, and she's been mobilized as we speak. And there's another patient who has a fiber optic endoscopic evaluation, which is what is seen as the swallowing difficulties and everything. There's my lovely team who I work with day in and day out, without which I would not be in a position to do. I have lots and lots of owing to them. This is my team, and I lead them and take it from there. There's another patient who's having a pedicure as their kind of things, and look at the post-COVID world, how elegant it looks like for them to come out of the ambience and they feel normal as they are. And this is some of the kind of strategies we allow. So in summary, COVID is a multi-system disease. Rehabilitation and follow-up is essential. If you miss them, the patients do come back to the hospital. But however, it needs to be directed follow-up based on what you are seeing in the intensive care and the hospital stay. And you need to have, in the follow-up, you need to have a high degree of clinical vigilance, especially in the moderate to severe kind of a patients. And we need further research to see what are the common complications. We have started the EPIC study, which is the estimate of the post-intensive care survivors, which I'm the chief investigator for that. And I would be in a position to speak to you about it in a year with the results being published. Thank you very much for your patient listening. And if you have any kind of suggestions, do not hesitate to contact me in the email as it is there. That's my university email, and that's my work email. Please do not hesitate to share with me anything. Thank you very much for your patient listening. I'm more than happy to take any questions if they are.
Thank you very much, Dr. Ram. So
Yep.
my network is a little bit unstable, so that's why. So I stopped my video. So thank you so much. Here a lot of questions are for all the three eminent speakers. So first question to Dr. Prabhu. So pregnant itself is an hypercoagulable state, and particularly if the third trimester pregnant patient came with raised D dimers, what is the protocol, sir? Dr. Prabhu. Vinay, can you unmute the Dr. Prabhu?
Okay, sir.
Vinay, three speakers unmute చేసేయండి.
Please unmute and respond. There is an unmute pop-up on your screen.
Three speakers unmute చేయండి.
Yes, sir.
Yeah, Prabhu.
Sir, I have sent an unmute pop-up for all the three speakers. So, Prabhu garu, మీ స్క్రీన్ మీద అన్మ్యూట్ పాపప్ వస్తుంది. ప్లీజ్ క్లిక్ ఆన్ దట్. Sir, it's not responding.
Dr. Ram Babu, we have sent.
Yeah, okay, sir. Dr. Prabhu is not there. So, Dr. Narasimhan sir is there online?
Yeah, Ram Prabhu.
But increased CRP seen in after post-COVID also after 1 month to 2 months. Is it any indications of steroids for that? Or otherwise, just we will leave it and we have to see. Increased CRP, raised CRP even after 1 month or 2 months.
No. CRP elevation alone is not an indication for steroids. If the patient has symptoms associated with biochemical marker elevations, there is an indication. Otherwise, you'll be treating only the biochemical marker, not the patient.
Okay. So post-COVID say anything or otherwise it's a normal diet only? Dr. Ram?
Sorry?
Yeah, please.
I can't hear you. So, sorry. Can you frame the question?
Yeah, Dr. Ram, post-COVID diet.
Post-COVID?
Any diet restrictions is there? Diet habits. So
Dietary restrictions, Ram.
So one person asked.
Right. No, there's no
Yeah.
requirement for the dietary restriction, but we have a specialized dietetic program for them because the COVID, we do metabolic measurements where the COVID is identically to the sepsis, where there's a significant amount of a catabolic state. So, which alludes that there's a significant protein loss. As Dr. Narasimhan has alluded to, the CRP rise is maybe because of the body's rebuilding capacity or the acute phase reactants, and therefore sometimes that alludes that there's a significant amount of a protein metabolic loss. So therefore, it's very important that the protein-rich food is being given to them, and we have a dietary processes where we have high fat, high protein diet that's quite given for our post-rehabilitation kind of a patients. I do not know about the long-term food habits, but I personally, there's nothing I would really like to have a diet restriction, but rich in protein, yes. Probably I have to add this. Everyone
Thank you, sir.
Vitamin D.
Yeah. Vinay, I am audible?
Yeah, very much, Dr. Rambab.
Yeah. Thank you, sir. So next question is there is increased alkaline phosphatase for some patients. Which is there any effect over the kidney will be seen on kidneys? Increased alkaline phosphatase and increased uric acid levels are seen in some of the patients.
Yeah.
So what to do with this patient?
Yeah. Now, what for the time this thing, I did not talk about the other manifestations. Yeah, these patients do have a significant amount of a renal problem as well, and as a result, it's quite direct and indirect, and there has a significant alteration of the vitamin D metabolism. And if you look at the bone state, bone profile of these kind of patients who have been there on the prolonged intensive care stay, I'm talking only about the intensive care patients. There is a metabolic bone loss, which is directly because of the long stay and also because of the vitamin D, the loss of vitamin D, and that's quite commonly seen in most of our patients. Therefore, the alkaline phosphatase is related to either the bone demineralization directly or secondary to the renal kind of a problems. So therefore, you need to have a watchful eye on the
is that enough?
Yeah, please.
Check. You are leaving the hospital.
Okay, sir. Dr. Prabhu is online.
Yes. Hi.
Yeah, Prabhu, we are also.
Yeah, you lost. Yeah.
Yeah, I just joined with a different device.
Okay, right.
Sorry.
So I asked about the pregnancy management in third trimester with raised D dimers. What is the protocol, sir?
Yeah, see, the RCOG, as Royal College of Obstetricians and Gynecologists, have given some guidelines. See, basically, pregnancy is a thrombophilic condition, and patients who become COVID positive during their pregnancy, you should consider thromboprophylaxis. Now, again, if they are unwell and they get admitted to ICU, etc., the standard protocol applies. Like maybe a dual dose thromboprophylaxis. If they get admitted to the ward, then just standard thromboprophylaxis. But in patients who are, it's a very difficult, very gray area, but if a pregnant patient becomes COVID-19 positive, then definitely there's an increased there's an increased thrombotic tendency. There is a role for giving low molecular weight heparin prophylaxis for about 2 to 4 weeks during the time of COVID infection. Of course, if they've had previous thrombosis and other issues, then maybe you can give extended thromboprophylaxis.
Dr. Rambabu, can you check? I think Dr. Ram was stopped abruptly when he was answering the previous question. Please check.
Yeah, he lost his thing. Dr. Ram?
Yeah. Sorry, it's just one of those things.
Yeah.
So as I said, the alkaline phosphatase and the uric acid are very important for us to just kind of make sure that you have a long-term renal profile being maintained. They all have a significant risk of developing a renal stone formation in the follow-up.
Okay, in the meantime, I think we again have an issue with Dr. Rambabu's network. There are few people who have raised your hand. So I'm going to send a unmute prompt to you. The participants are free to come online and ask questions. So there is Veera Bhadraya. Make an unmute prompt పంపించడం. Doubts ఉంటే అడగండి.
Is that audible?
Okay. Over everybody's hands, and I'll ask anyone who wants to speak, please raise your hand and ask the question. We'll take you online. Vinay, can you guide them how to raise their hand?
Yes, sir. Uh, you can find the raise hand option on the right bottom of your screen. మీకు రైట్ బాటమ్ కింద 3 dots ఉంటుంది. Click on that. You can find a raise hand option. Then that will be pop up in your participant section. Richards gar hand raise చేసి sir.
Yeah, please send him unmute prompt.
Richards garu unmute and respond.
Sir, good evening, sir.
Yeah, good evening.
Sir, for few patients, there might be necessity of long-term steroid administration. Like more than 4 weeks, there may be possibility of long-term steroid administration. So, is there any role of steroid sparing agent like mycophenolate or azathioprine, sir?
We have Dr. Rambabu also online. In the meantime, I request speakers, 3 of you, anybody who feels comfortable with this question can go ahead and answer.
Yeah, I think Dr. Ram can give this. Dr.
Yeah.
Ram?
Yeah.
Yeah, if prolonged steroids are using, is there any role of going for the immunosuppressive agents, mycophenolate or the azathioprine or anything? Are you using any time like this patient?
There's only one indication for long-term steroids in these kind of patients. I'm sure Dr. Narasimhan would agree, is the potential ongoing fibrosis for this kind of a patients. And I personally do not know because I'm not a pulmonologist, but Dr. Narasimhan may be in a position to answer to that. And there's a trial which is going on comparing the steroids with anti-fibrotic agents. One of these centers is AIMS in India, and the results are not too sure. But mycophenolate, mofetil, I do not know, but the specific antifibrotics. Dr. Narasimhan, could you elaborate on that?
Yeah. Actually, there is no role for mycophenolate. Mycophenolate is not being tried in that in preventing fibrosis in COVID-related fibrosis. Mycophenolate is not being tried. Actually, the subgroup that needs an antifibrotic in COVID fibrosis itself is quite small. Because in the early phase of the post-COVID problems, people used to think. Actually, there is an article in NEJM also where they were using nintedanib and pirfenidone in patients with fibrosis. But now people are realizing that most of these fibrosis are self-limiting. They get better. Majority of them. Only a small group of patients need antifibrotic drugs if you can demonstrate the peripheral fibrosis and blebs. In such patients also it is an off-label indication. In such patients also it is only either pirfenidone or nintedanib and not mycophenolate. Mycophenolate is not being tried for this COVID-related fibrosis.
Thank you, Narasimhan. We have
My opinion, I'll add on to that. In my opinion, it is the steroids that are going to be of greater use in COVID-related fibrosis rather than mycophenolates or nintedanibs or pirfenidones. Because there is a direct relation between the immunological mechanisms, the immunological marker elevations like the IL-6 and the LDHs and the ferritinins and other immunological markers that are elevated, which can be better suppressed with corticosteroids than with nintedanib and pirfenidone, which acts through a different mechanism in reducing the fibrosis.
Thank you. We have
Thank
brought
you, sir.
Krishna Kale.
So, person
Yeah.
to
Okay, Rambabu garu.
Yeah,
Krishna Kale okadu unnaru. Please take
Yes,
it.
sir. Krishna Kale. This is Krishna
Yeah.
Kale.
Yeah.
Sir, we have noticed that some post-COVID cases treated with steroids has elevated levels of triglycerides and lipid profile. Do we have to treat them with anti cholesterol drugs? Can you hear me, sir?
Yeah, you are audible.
Yeah, I can hear you. Yeah.
Yes, sir.
As of now, as I told you, COVID is one thing that is making us learn each and every day. Each and every day we are learning something new in this actually. If you find an extremely high dyslipidemic state in the post-COVID situation, there are two things that can happen. That is possible. One is this person was prone for a dyslipidemia for a long period. COVID has unmasked it, which needs to be treated, and he needs to be followed up like you do for any other dyslipidemic states. Because in the post-COVID state, people do have tachycardia, do develop ischemic heart disease, do pulmonary embolism, which means one of the predisposing factors for this coronary events in ischemic heart need to be treated, and one of them is hypercholesterolemia and hypertriglyceridemia. I think we need to treat them. But there is no last word as yet. If you ask me what is the data, is there any evidence for it? I don't think. It will take another 1 year for us to come with some guidelines on these aspects of hyperglycemia following COVID, hypoglycemia following COVID. There are lots of new things, hypertriglyceridemia following COVID, which we are noticing in these patients. I think the last word is not yet out. It will take some more time for us to come up with guidelines.
Okay. Thank you, sir.
Yeah, thank you, sir. So there is another question. Sinus bradycardia, how often it is common, and how are you giving any treatment or just leaving it?
Can I take a question? Yeah, sinus.
Yeah. Please.
Sinus
Oh,
tachycardia
yeah.
is quite. Yeah, sinus tachycardia is quite very common, and it's because that's many of the patients who presented with the myocarditis do present with sinus bradycardia. And much more is all those patients. Initially, we used to start treating the patient with hydroxychloroquine in the community, and they come to us, and at least 1/3 of them do develop some kind of a QTc prolongation and sinus bradycardia, which eventually turns out to develop a ventricular tachycardia. That's not very good sign at all. So the sinus bradycardia alludes that the strands or the electrical strands from the atrium to the ventricle is not really good. And most of the sinus bradycardia, they develop AV nodal disease rather than the sinus nodal disease. That's quite very clear. So it's not very uncommon for these patients. And these are the patients you need to be thinking and worrying about sudden cardiac death.
Yeah. Thank you, Ram. So
that incidence is relatively low, Ram.
The incidence is.
We often come across TAC. COVID TACs are more common. Tachycardia is more common in the post-COVID phase. We come across tachycardia. Bradycardia, we have not come across much of bradycardia. Like you said, they go on for ventricular tachycardia. In the ICU phase, we have seen many COVID bradys. But in the post-COVID phase, we have not had sinus. That is an interesting question. They had sinus brady in the post-COVID. I have not had any. I don't know about your experience, Ram. Did you have any sinus brady in the post-COVID situation after the patients were discharged and they came back? Post sinus brady? I have not had any so far.
So in a kind of I don't have the exact picture in my mind, but our incidence of sinus bradycardia in the intensive care patients at presentation was about 5 to 10%, which is quite 5 out of 100 to develop this kind of things. As you rightly said, the tachycardia and the ventricular tachyarrhythmias is much more common, but the prognosis
more common in the post-COVID phase.
Yeah, the prognosis of those patients who have sinus bradycardia is much worse, and that alludes that there is a significant right heart failure.
Yeah, thank you very much. So there is a final question about the post-COVID renal manifestations. Can we identify early?
I didn't talk about that because of the time. Yes, you can identify it earlier. The initial presentation, majority of the renal failure that presents to us from our data is acute tubular necrosis, right? This could be either because of the thromboembolic mechanism, or it could be because of the cytokine-mediated acute tubular necrosis, or sometimes the patients present late, not eating and drinking, so simple hydration and hypotension related kind of acute tubular necrosis does happen. Now, amongst the three, the patients who require filtration, CVVHDF, and who are discharged from the intensive care with CVHDF develop long-term renal kind of a problems. And we are seeing the patients about 6 months about the usual the renal failure in those patients who are admitted with the renal failure at presentation. The long-term renal complications are up to 10 to 15% of the patients. That is, 1 in 10 will have a long-standing renal functions. This is up to the 6 months data I have, but I don't have the longitudinal data. But the patients with a pre-existing renal disease apparently ended up in an end-stage renal disease, and they are requiring on a regular dialysis mode. So renal problems are common.
Yeah. So thank you very much. So all the speakers, particularly, so we have come to some conclusions like post-COVID dry cough is very common. Post-COVID fatigue is also very common. And there is a possibilities of raised CRP, but not that much worry. Single CRP cannot be go for the steroids. And also that there is acute tubular necrosis. You have to identify little bit early. And bradycardia or the tachycardia is also the common. Post-COVID dietary habits, rich protein diet, and post-COVID exercises, the psychological impact, and breathing exercises, planning, pacing, prioritizing, positioning. So all these things are we have discussed today webinar. And really, I thank you very much for the particularly the Dr. Narasimhan, so who is stalwart in the pulmonology and 29 years of experience, and he is a specialist also. And we are sending so many cases from Chitturu to him, and so many VIPs already treated. Thank you very much, sir. You have given a lot of time to us in spite of that much of busy schedule in your hospital. And Dr. Ram, really excellent presentation from your side, and you have taken a lot of time, so you're asked for 1 hour permission, but I'm sorry that I have not given to you that one. So
No, it's
all
okay.
the times you are here for the 2 hours, 2.5 hours, really. Thank you. And Dr. Prabhu, so you are also excellent as clear. So many slides are there, so I'll try to share to all my people. So all the doctors, so excellent presentation, and questions also very nice. So I think Dr. Vinod is the line. So you want to say anything, sir?
Yeah, it's a wonderful webinar. In fact, I didn't know the 2 hours. I was totally involved into it. I felt like I entered through trachea, then into the large vessels, medium, small. I emerged out into the internal milieu. So it was a wonderful representation. I would rate one of the best presentations we had in the series today. So thanks to Dr. Ram Babu for conducting this. We had a small glitch with your network, but that's wonderful. The big thanks I would like to give to the participants. We have doctors participating from primary healthcare centers till one of the best uh, corporate hospitals we have in Andhra Pradesh. The few were asking us to continue this program. Yes, this is a fixed program every Tuesday, 3 to 5 p.m. We are having this webinar in which all the doctors have participated, all the institutions have participated really well. Thank you. A special thanks to the overseas speakers because you are attending there from your odd times. I request Dr. Ram Babu to take the alignment of the speakers if it is okay for them to share the PPTs with our doctors, and also if we can have the recording of this to be kept as record with us and for reference. Thank you everyone and have a great day.
Thank you very much, sir. So with this, so we are closing our conference. Thank you.
Okay. Thank you. Thanks, Rambabu. Bye.
Thank you. Thank you very much. Thank you, all the speakers. Thank you.